TMS नहीं होता and Dr. Kumar will be introducing the materials to the Thank you, sir. So when we talk about psychiatry, the common perception is that talk therapy, psychotherapy, or shock therapy. So psychiatry is more than that, and the emerging technique is neuromodulation. So, Deep TMS, we are going to present a case that is a kind of neuromodulation technique. There is no recent one, aspect of neuromodulation. So, Deep TMS is basically transcranial stimulation, one medicine, and deep means to go a little wider and deeper, so that it precisely target traffic area of the brain to achieve the desired. In fact, you look at neuromodulation, any technique that is state of the brain would be speech, music, because it's stimulate the brain. But conventionally, when we mechanically stimulate the brain, we call it neuromodulation. So, the department is using the TMS technique, neuromodulation technique, since 2009. And with our work with this clinical and research, we got awarded by the Center for Advanced Research and Accidents by AIIMS in 2009. So one of the national Center for Training of Information Technique with the psychiatrists, neurologists, and the technologists also. So the neuromodulation technique is commonly used and approved for treatment of depression, TB, migraine, clinical conditions like this. Patients are going to present or having a depression, which they are going to. So we use Deep TMS technique to treat the patient with very good outcome. We will present what we do. Thank you, sir.
So, I welcome you all to today's presentation, case of severe depression with severe blepharospasm, a deep TMS approach. So, this is the initial introduction, which shows the number of patients who have been treated using TMS at AIIMS over the years, starting from 2009, and this number has been gradually increasing. And till now, we have organized 6 hands-on national workshops and 9 CMEs on neuromodulation. So I'll just be introducing the topics which we are going to present and the manner in which we are going to present. So first, we are going to have psychiatric clinical case presentation, followed by ophthalmological evaluation and management, followed by neurological evaluation and management, and then finally psychiatric diagnosis in Deep TMS, followed by his comprehensive management and course, followed by an fMRI study, followed by concluding. So with this, I would like to invite Dr. Ujjwal to present the psychiatric clinical case presentation.
Good afternoon, everyone. I'm here to present the clinical history of the patient. He's a 46-year-old male, unmarried and appeased, came to us with presenting complaints of दोनों आंखों में बार-बार तकने और एटम की समस्या है from the past 2 years. मन उदास रहता है from the past 6 months. मुझे नहीं लगता मैं ठीक हो पाऊंगा from the past 6 months. His total duration of illness is 2 years. Depressive symptoms have been present from the past 6 months. Onset of the illness is insidious, scores continuous and deteriorating, and preceding factor will not be established. In 2022, during his pre-morbid level, patient had a stable mood, adequate social interaction, normal sleep and wake cycle, appropriate self-care. He used to practice pranayama for 1 hour and give daily orations to his followers and read sacred texts in his free times. In August 2022, he felt unusual tightness around his eyes, a strain and occasional fluttering, and he had difficulty in opening his eyes. 3 to 4 months later, it started hampering his daily routine. Episodes of the blinking became more frequent. He struggled to keep his gaze steady, especially during bright light or while reading the texts, and had difficulty to focus during meditation and orations. He received 8 Botox injection during the course of his illness, and last injection was given in August 2023, on which he only reported minimal improvement. From Feb 2024, there was gradual worsening of his symptoms and frequent involuntary closure of his eyelids. He wouldn't allow light to come inside his room and would cover his head with blanket throughout the day. He had irritable mood and persistent and pervasive low mood. Simple tasks felt burdensome, and there was lack of concentration and inability to maintain steady focus. He had inability in carrying out his spiritual duties. He was unable to give his daily orations, and there was decreased social interaction, a sense of generalized weakness, lack of confidence, and withdrawn from social gatherings as well as from spiritual gatherings. He developed ideas of hopelessness due to multiple treatment failure, and he had sleep disturbance present due to persistent eye discomfort. In May 2024, he underwent partial bilateral myectomy, and there was no improvement on he presented to us in August 2024. At presentation, his status was he had fluttering of eyelids and he was intolerant to bright lights. There was persistent and pervasive sadness of mood. He had ideas of hopelessness regarding the treatment. He had decreased interaction and difficulty in reading and giving orations. His examination findings revealed his facial expression conveyed discomfort, particularly when exposed to bright light, and he had frequently blinked his eyelid. He refused to open the curtains for light and covered his face with a blanket when the clinician arrived. He was cooperative but inattentive. There were signs of frustration and distress when discussing the prolonged struggle with the condition. He had an anxious effect and was hopeless regarding the treatment. For the course, multidisciplinary approach involving teams for neurology, ophthalmology, psychiatry, and NMR was taken for evaluation and management. Now I would request Dr. Himani Thakur from Department of Ophthalmology for her presentation on ophthalmological evaluation and management of the case.
A very good afternoon to one and all present. So I will be carrying on the discussion further. So when the patient presented to us, we asked him about his complaints, and he had history of increased frequency of blinking since 2 to 3 years and inability to open both eyes since 1 year. He had received multiple injections of botulinum toxin, minimum 8, and last he received in 2023. Also, there were documents of bilateral orbicularis myectomy, which was performed in May 2024, although the extent and exact details of the surgery were not available to us. On ophthalmic examination, we saw that there were bilateral upper lid conjunctival congestion and few follicles. Otherwise, the anterior segment and posterior segment were normal. So based on the history, we considered the diagnosis of benign essential blepharospasm, but since DEB is a clinical diagnosis, so we always rule out secondary blepharospasm. So as a treatment, we advised low-dose steroid and lubricants and anti-allergics so that we can review and ask the patient the further symptoms. When the patient was reviewed after 4 weeks, the patient had some symptomatic relief objectively. Like when we saw the patient, we saw that there were improvement in the follicles, the redness had decreased, the papillae had reduced, but the patient's blepharospasm was more or less the same, which reinstated our diagnosis of benign essential blepharospasm. That is why we tapered all the steroids and continued the lubricants. Thank you.
Good afternoon, everyone. I'm Dr. Himani. So, from neurology point of view, so on receiving the referral from the Department of Psychiatry and from the Department of Ophthalmology after their basic preliminary evaluation, so we reviewed the history in details again, and on examination there was this bilateral tonic contraction, involuntary tonic contraction involving both the eyelids, and the rest apart, the neurological examination was essentially within normal limit. But the fact that the severity and the frequency of the eye closure was getting fluctuations from time to time and from observer to observer. So that raised a red flag of having these fluctuations, and there is also partial relief on good rest and sleep. And in that too, on the background of severe depressive symptoms and insomnia that the patient was having for quite a couple of years. So that raised a significant red flag as to whether we're dealing with only the primary essential blepharospasm or there is something functional component to that. So we went ahead with the routine neurological evaluation setup. For example, we first went on for the routine MRI scan to rule out, to see for any structural brain pathology that could be causing the blepharospasm itself, but that came out to be normal. So it ruled out any structural lesion per se. The surface EMG, although did reveal there is this increased activity noted in both the frontalis and both the orbicularis and ocular bilateral. But the neurologist who performed the surface EMG did a special note of that there is distractibility was significantly present even during the procedure of the surface EMG. The blink reflex also came out to be normal both in R1 and R2 latencies and morphology. So he kept a final diagnosis after evaluating clinical evaluation and the whole examination. So he kept a final impression as to be a primary essential blepharospasm, which was in line with the psychiatry and the ophthalmic colleague, but with significant functional overlay. So since there was a significant functional overlay, we didn't upfront went for the Botox therapy, and we wanted the primary functional component to be taken care of first. So we didn't went upfront for the Botox therapy, and we wanted the depression to be managed first. So we referred back the patient to psychiatry for the primary management of depression. Sorry, Botox. There is a abbreviation of Botox therapy. Botulinum toxin. Yeah, botulinum neuro. N for neurotoxin. Yeah.
Botulinum toxin in the compound, so we don't mention the great name.
Yeah, sure. Sorry for that. So just a short note on typically differentiating the functional blepharospasm from the organic one in context with the patient that we are dealing with. So the patient had on onset that the patient had significant history of stresses, and also the patient had significant component of distractibility both in during the history and the examination. Also the patient had some similar triggers of emotional stress that were triggering this blepharospasm component to that. The sensory was typically absent, which is usually remain present in the organic blepharospasm, and the icosol was bit of towards the forceful side. So all these components gave us a clue that there could be some significant function to that. So we referred the patient back to a psychiatry department, and the rest of the course will be taken care of by Dr. Gagan, from psychiatry.
Thank you. So with the significant inputs from ophthalmology, neurology, and also getting the scans of the patient, we arrived at the diagnosis of benign essential blepharospasm with depression. Now, this case had some issues and challenges, some of which were very unique to the case. Like there was a chronic and progressive symptoms. The patient has had symptoms for the past 2 years and had multiple, there was no relief in the symptoms despite treatment seeking. So treatment resistant, as already mentioned, he had received 8 sessions of Botox and partial myectomy, which had failed or only provided partial relief to the symptoms of the patient. It was having a significant impact on the daily life of the patient. So as to, at the time of presentation, he was totally bound to his room. He was not able to practice his spiritual duties. He was not able to perform his spiritual duties. There was significant emotional and psychological strain, but as the patient has all the subjective distress, he attributed all of this to his primary symptoms of blepharospasm. There was multiple treatment seeking, and before the patient has come to us, he had sought almost around 84 consultations at different places, and multiple interventions had been tried. Since the patient was a priest of a very high order, so he had access to treatment facilities around the world, and he had not only sought these consultations in India, but abroad with multiple specialists as well. Then there was a significant stigma associated with depression and anxiety. So although the patient whenever we tried to talk about the possibility of treatment of depression and anxiety, it was very difficult to put this across to the patient that a lot of symptoms could be exacerbated because of the comorbid depression and anxiety. And with this, patient had initially refused to take psychotropics. So when we suggested that patient should be initially started on antidepressants, there was a refusal from the part of the patient, although with some psychoeducation, patient agreed subsequently to start psychotropics. So we formulated a comprehensive plan for the management of the patient. We discussed with patient what are the alternative non-pharmacological interventions, including the TMS. for the symptoms management of the patient. And patient was educated about neuromodulation as a potential therapeutic approach for both depression and blepharospasm. So this aspect particularly kind of broke the ice with the patient, so that we have one intervention which can be used for both the conditions. And detailed information was given regarding the procedure and potential benefits of TMS in both conditions to the patient. So TMS, just briefly about TMS, is a non-invasive, safe and cost-effective method of probing brain functions. It acts through the magnetic field and it is painless. There is focal action potential in the superficial cortex with transsynaptic effects, and it induces electric current in the brain via Faraday's principle of electromagnetic induction. So this is the proposed mechanism of action where depolarization of neurons in the DLPFC, that is dorsolateral prefrontal cortex, in depression causes local neurotransmitter release. But this is not only kind of limited to the superficial areas. So there is depolarization of pyramidal neurons also causes neurotransmitter release in the deeper brain neurons. And activation of deeper brain neurons then exerts in secondary effects on the remaining portions of the targeted mood circuits, which are primarily dorsolateral prefrontal cortex and the ACC, anterior cingulate cortex. And these effects are then associated with improvements in depressive symptoms. So just briefly regarding differentiation of the traditional RTMS as compared to Deep TMS. So first two columns, you see that traditional conventional TMS uses a figure of 8 coil, which can only go up to a depth of 0.7 centimeters subdurally as compared to H1 coil, H7 and H4 coils, which are used in different conditions in Deep TMS. So all these are patented coils, and the first one, which is the H1 coil, is used in depression and thus was chosen in this case. So another difference is that traditional RTMS is very focused as compared to Deep TMS. So Deep TMS stimulates a very large portion of area, and not only the depth, but the area which is stimulated is also wide. So as such, there are no chances of missing out on the area, which were present in case of conventional TMS. So we did a comprehensive literature review that what is the literature which is present for the use of TMS in blepharospasm, and we found limited studies that it has been used for the treatment of TMS, especially in cases where the initial two, that Botox and myectomy have failed to yield any sort of result. So synopsis of the literature which we received was that modulation of cortical excitability in ACC and related circuits reduces abnormal eyelid contraction with the TMS. The areas which stimulated are ACC, dorsolateral prefrontal cortex, supplementary motor area and motor cortex. And Deep TMS is equally efficacious, but there is need for repeated sessions. There was some literature which suggests that if TMS is used in conjugation with Botox, the results which were achieved may be superior, and it may, if especially in patients with comorbid and anxiety, the TMS is associated with better outcomes, and it is a safe and efficacious modality for both blepharospasm as well as anxiety and depression. So with this, now I would like to call Ujjwal to carry forward. Thank you.
Coming to the treatment course, following the psychoeducation sessions, patient agreed to undergo Deep TMS sessions. His detailed evaluation of the patient, including presence of any contraindication of procedure, was carried out, and we used the FDA approved protocol that we used Deep TMS in depression, and it was set. Coming to the Deep TMS parameters, the coil we used was H1. We were giving him 5 sessions per week, and we delivered a total of 22 sessions, and each session duration was around 20 minutes with following Deep TMS protocol. We monitored his response on MADRS scale, which is used for depression. You can see the graph from initial score of 34. After the end of 22 sessions, his score was 7. This scale we used Jankovic rating scale for blepharospasm, and we measured the severity as well as frequency of blepharospasm, and progressively the graph showed improvement. And we also measured his clinical improvement. At baseline, he had difficulty in opening eyes, frequent blinking. He was functionally blind, intolerant to bright lights, dependent on his caregivers for his daily activities, and was socially withdrawn. After fifth session, there was minimal improvement, less frequent blinking. He was able to do his self-care by himself by now and still intolerant to light and socially withdrawn. After 10th session, patient started doing all his activities by himself, including self-care, allowed light to enter inside his room, and there was improvement in his sleep. After 15th session, he started reading religious texts and interacted with people. Couldn't concentrate on reading for more than 10 to 15 minutes. And after 20th session, there was significant improvement that was noticed. He was able to read small text in newspaper and religious texts for more than half an hour. And after 22nd session, there was significant improvement in mood and blepharospasm frequency and severity. By this time, he became completely functional. The current status of the patient is in treatment. He received 8 to 10 maintenance Deep TMS sessions locally and is compliant to medications. In functioning, he is regularly delivering orations to his followers without any difficulty. He is actively engaged in recording and sharing podcasts. He maintains adequate social interaction and continues his spiritual teachings. His sleep cycle is improved and he follows his daily routine effectively. He is functioning well in all aspects of life without any ongoing symptoms. I would like to invite Dr. Priyanka from NMR department for the fMRI study.
So now when it was decided that the functional component had to be treated by Deep TMS, so we were roped in to understand that how Deep TMS would have taken effect. So we designed a two-pronged approach to it, a task-based functional MRI study as well as a resting state fMRI study. In the task-based fMRI study, we used a visual motor task to address the issue, in which during an alternative sessions of active as well as rest sessions were given to elicit any brain activity pertaining to the cortical regions. So during the active sessions in visual motor task, a checkerboard was given, and the rest session included a blank screen. We also gave a sensory task during which some saline was delivered during the active session. Since he was a priest of a very high order, it was not advisable to elicit a sensory response by touch. So we resorted to this issue where there would be minimal touch of that sort inside the scanner. In case we would miss any activity elicited by the task-based fMRI, we resorted to resting state torch lighting method, wherein the default mode networks or the salience network or sensory motor network would be evaluated pre and post TMS. So we did the fMRI sessions at the baseline and after the full sessions of TMS were done. At the baseline in the visual motor task, we can appreciate the difference in the activity. So we have to focus on this intensity scale, wherein as in the yellow the intensity scale gets, it indicates an increase in brain activity. So at baseline, we can see that there is not much increase in activity, but at follow, we can see in the motor regions, we have some activity. And similarly, in the sensory task, we could see some frontal regions popping up, and it was interesting to see that it was a very plain slate at the baseline. Next, since we had also done the seed-based connectivity using resting state fMRI, so we chose to focus on default mode network and sensory motor networks. Default mode networks again here elicited a nice increase in cortical connectivity in the frontal regions, and it was also interesting to see that these frontopalatal regions where there was an inhibitory connectivity as corresponding to this this intensity scale, this the cluster size of this had gradually decreased. Similarly, in the cingulate cortex of the default mode network, we could again see the decrease in inhibitory connectivity and some frontal cluster size getting increased as a result of treatment regime. Sensory motor network showed the most increase in cortical connectivity as corresponding to the intensity spectrum. So we thought that these changes could be attributed to the treatment regime that was given. With this, I would like to conclude and request Dr. Nand to conclude.
Thank you all. So, the patient was presented was having a primary essential blepharospasm with comorbid depression and anxiety, and that was leading to significant distress And so we adopted a multidisciplinary approach, psychiatrist, neurologist, plus FMRI team, so that we can show some evidence base. Because one of the challenging part was the patient was not willing to accept that he has some sort of depression or anxiety. But when we explained in a more neurobiological way, then he understood and he got agreed for Deep TMS. So evidence what we got in FMRI that proved to us and the patient also that it helped, the Deep TMS helped in the treatment, and subsequently he agreed to take the medication also. So that was the best part, and still the patient is functional and doing well without any maintenance therapy. He's just maintaining on medication. Thank you so much. So I would be happy to have any clarification or comment.
When did you start taking the medication? Did you start right away?
So initially there was some resistance, but he started medications prior to onset of therapy. Then his doses were pretty low, and the response came within 10 days, which is unlikely that it was because of pharmacotherapy.
Usually with antidepressants, we expect about 6 weeks, but we got 6 weeks.
Yes.
In your other patients, you get as quick a response when you get.
So not usually, but then it depends on patient to patient and depends on the disease specific variables also. Some patients.
How often do you use it for depression?
So it is used very frequently. We have around 3 to 4 patients per day who undergo TMS. So it's not just for this, but it's FDA indicated for OCD as well. So we have around 10 to 12 patients per day, where around 6 to 8 patients for OCD and 4 to 5 patients who would undergo it for depression.
Dr. Nand, any final comments? Thank you everyone for your attentive listening, and I'll now hand it over to the orthopedics department. Dr. Smith.